More than 50% of individuals who suffer heart attacks present with normal or low LDL levels at the time of the event. Conversely, data from over a dozen studies focused on elderly populations shows that higher LDL levels correlate with greater longevity, not reduced survival. The numbers contradict the clinical baseline. The confusion begins with a basic error in terminology. LDL is not cholesterol. LDL stands for low-density lipoprotein. It is a protein-based transport molecule, synthesized by the liver, engineered specifically to carry materials through the bloodstream and deliver them to cells. One of those materials is cholesterol, a structural compound required to form cell membranes and synthesize steroid hormones like testosterone, estrogen, and cortisol. But the delivery manifest extends much further. This LDL vehicle carries a massive load of antioxidants, delivering 45% of circulating vitamin E and 76% of all carotenoids to body tissues. It also transports coenzyme Q10, a compound strictly required for healthy cardiac function and mitochondrial energy production. By treating an essential biological delivery system as a default pathogen, clinical models obscure the actual child-riser cardiovascular risk and establish a baseline of flawed assumptions. This is a standard clinical blood test report. The total LDL metric highlighted here is reported as a single number, a measure of weight per unit of blood volume. A simple mass measurement is clinically incomplete. It evaluates weight but ignores composition, failing to distinguish between two highly distinct subtypes of LDL particles. This cross-section demonstrates the first subtype, large, buoyant LDL. Being non-pathogenic, they bounce harmlessly off an intact endothelium. The second subtype, small, dense LDL, slips through microscopic gaps, lodging inside the wall. Once trapped, they oxidize, triggering an immune response that begins plaque formation. The resulting arterial plaque consists of approximately 60 to 87% fibrous tissue and calcium. The cholesterol found within that plaque originates primarily from oxidized dead white blood cells, not directly from circulating dietary cholesterol. Metabolically healthy individuals, particularly lean mass hyperresponders following low carbohydrate diets, often present with incredibly high total LDL mass, yet they possess exclusively harmless, large, buoyant particles, showing zero elevated risk. A high total LDL mass reading is irrelevant if the particles are geometrically incapable of penetrating the endothelium. Volumetric testing cannot evaluate heart disease risk accurately. Evaluating true cardiovascular risk requires ordering an advanced lipid profile, commonly called a particle size test, to map exact LDL composition. The most critical marker on that profile is apolipoprotein B, or ApoB. This metric measures the total absolute number of LDL particles circulating in the blood, regardless of their individual size. This scale illustrates the relationship between mass, size, and particle count. A single large particle carries substantial cholesterol. To carry that same mass requires multiple small, dense particles. With high concentrations of small particles, the absolute number must multiply rapidly to transport required cholesterol. An elevated ApoB count acts as a highly accurate proxy. High particle volume directly indicates a dangerous predominance of the small, dense LDL subtype. Measuring circulating triglycerides provides the second half of the picture, serving as another required metric to evaluate an individual's actual metabolic health alongside particle size. Without measuring specific particle count and physical dimensions, standard lipid testing often triggers medically inappropriate interventions. This flowchart illustrates the difference between epidemiological association and biological causation. Owning a television correlates heavily with increased heart disease risk, but doesn't cause heart attacks. It is merely a statistical proxy for sedentary behavior, leading directly to metabolic dysfunction. In decades of cardiovascular research, LDL frequently occupies the exact same associative position as the television. It sits adjacent to metabolic dysfunction in the data, rather than acting as a direct biological cause. This associative blurring is common in nutritional cardiology. The PREDIMED trial is the most heavily cited dietary intervention study in the field, credited with proving the Mediterranean diet significantly reduces heart attacks. The trial's methodology collapsed under scrutiny. The control group, instructed to eat a low-fat diet, actually consumed 37% of their calories from fat and received zero dietary support. The intervention group consumed 41% fat. In 2018, the New England Journal of Medicine retracted the study. Investigators discovered that 21% of the trial's participants were never properly randomized, directly violating core scientific methodology. Dietary randomized controlled trials carry severe inherent constraints. Researchers cannot blind participants to the food they eat, nor can they perfectly isolate variables like food portion sizes, food preparation methods, and individual metabolic variation. Sweeping clinical dietary guidelines are routinely built on these exact types of uncontrolled trials, conflating messy lifestyle associations with hard biological causation. Before its retraction, the widely publicized headline from the PREDIMED trial stated that the Mediterranean diet delivered a 30% reduction in cardiovascular events. That statistic relies on relative risk reduction, a comparative ratio between two groups. It actively masks absolute risk reduction, which is the actual difference in real-world probability for a single individual. These matrices represent a baseline of 100 people per group. In the control group, 4 people experienced a cardiovascular event. In the intervention group, 3 people experienced an event. The 30% relative reduction translates to an absolute risk reduction of exactly 1 person. Apply this exact mathematical lens to statin medications, which are widely cited in clinical literature as delivering a 29% relative risk reduction for heart attacks. The absolute reality of statins looks much different. Their absolute risk reduction is approximately 1.3%. For every 100 patients prescribed statins, roughly 99 will derive zero measurable prevention of a cardiac event. Relying on relative risk statistics mathematically exaggerates therapeutic efficacy, obscuring negligible absolute benefits and misguiding clinical treatment priorities. Statins lower total LDL by deliberately blocking the liver's internal enzyme pathway for cholesterol synthesis. This close-up rendering of muscle fibers illustrates the collateral damage of that blockage. The same enzymatic pathway produces CoQ10. Shutting it down directly causes the severe muscle pain, weakness, and fatigue commonly reported by patients. The downstream consequences of blocking this synthesis include impaired sex hormone production, diminished cortisol capacity, and a severe reduction in the bile acids required to digest fat-soluble vitamins. Shifting focus away from pharmacological suppression reveals the true physiological drivers of dangerous, small dense LDL, systemic inflammation, and insulin resistance. These specific metabolic dysfunctions are most frequently driven by diets high in refined carbohydrates and sugars, not by the consumption of dietary cholesterol. Addressing these root metabolic causes naturally decreases the volume of small, dense particles, correcting LDL morphology without requiring pharmacological intervention. Achieving true cardiovascular resilience requires identifying and treating underlying metabolic inflammation, rather than reflexively crippling an essential biological transport system for a statistical fraction of a % in benefit.